you have a patient who happens to get testing in the setting of stage 3 and has PDL1 that comes back as 0. They get through chemo and radiation. We have an unplanned analysis of various subgroups in the Pacific trial that demonstrated a benefit of up to a year of durvalumab Imfinzi immunotherapy after chemo and radiation for stage 3. And in that subgroup analysis, the patients with PDL1, the protein associated with more or less benefit from immunotherapy, the patients who had 0 expression of this protein didn't seem to benefit from durvalumab. How do you use this information when you're sitting down with the patient? Presume they don't have any warning signs to suggest they shouldn't get it. Do you present this information? Do you suggest that this is probably not worth their while? Or how do you frame this information?
I guess I have to admit that in my institution, we don't look.
If
you leave your head in the sand, you don't have to address this issue.
Don't ask, don't tell is an arguable point, and that's why I framed it as
right.
But sometimes
we know
it's done surgery. The surgeon, well-intended, thinks more information is better, or it's reflexively tested, or whatever. There's lots of circumstances where it could be that someone transfers care, but that die's been cast. So it's now your problem.
Exactly. And we should say out loud that different regulatory agencies have handled this differently. If you are in Europe and you're under the subject of the European Medical Agency, they didn't approve Imfinzi durvalumab for the 0%ers based on these data.
So that makes it easier.
Makes it easier for the European investigators not to even ask the question. But
I think have that option.
I think there are two things. One is that it gets into the weeds a little bit. PDL1 is a test that has come up in many permutations. Like every company that makes immunotherapy has a different PDL1 test. This company, the cut point they decided to kind of make most of their hay around is 25% higher or lower. And so there's some argument that the 22C3 that a lot of us do in a stage 4 setting,
22C3 being
a type of PDL1 testing,
the most common test,
versus the PDL1 that they did on this trial, where the distinguishing ability lower than 25%, meaning can you tell the difference between 0 and 5%? It's not quite as clear. Basically, my hand wavy answer is I do mention this to patients if I happen to know. I tell them that one part of the study suggested that the time of length of holding the tumor down was a little bit longer. There's a hint toward that, but the survival was a hint toward a little shorter, but these were very small numbers, and we kind of talk it through. And I would say that if a patient were more beaten up than average after chemoradiation, I'm less enthusiastic about the durvalumab or Imfinzi, or I'm more likely to stop it at 6 months if there's some adverse event. But I still offer it. If I had that data in front of me, I'd probably talk this through with the patient. But if they kind of said, "Doc, what would you do?" I'd have to scratch my head, gulp a little bit. And I probably, again, in this curative setting where I'm just going for the brass ring, I probably actually would take it personally. But I really would.
This is not a setting where there was a harmful effect. It was just maybe these patients didn't get a benefit as much as everyone else. But
and I'll be looking. We're hoping that this is specific. There's specific 1 through 8. Every other company is doing trials like this. I hope we'll have better data to answer this question when we talk in 2020 and 2021. But that's kind of where I put my foot down.
Well, I think yes, it's fair to acknowledge that one of the concerns is what can you minimize in terms of anticipatory regret? Will you wonder what if you don't do it versus if you had? Millie, what's your approach?
Yeah, I mean, I think I've had situations of patients where their baseline pulmonary function is not great. They are a little bit beat up after the chemoradiation. And then the consideration of durvalumab or not. If they're PDL1 0, I think I use that as maybe an additional kind of drop in the bucket against doing the durvalumab. And, and again, kind of having that discussion is important. And I've actually faced this clinical scenario a number of times in recent months, and have used that. The other thing that people are starting to look at is this concept of minimal residual disease, or MRD testing. So doing that testing in people after they've finished chemoradiation to see if there's any detectable circulating tumor DNA, and using that potentially. So kind of similarly to the PDL1 cutoff, if you don't see circulating tumor DNA, would you use that as a reason to not give durvalumab? And of course, we don't have answers to that, but in a situation where you're kind of on the fence, there are, I think, the PDL1 less than 0, the ctDNA, whether or not it's detectable, I think those things could kind of be part of that, balance of, should you offer it or not? Again, the risk benefits.